Respiration and swallowing are like two team partners who have to coordinate and work together in order to establish safe swallowing together. And if one of these team partners becomes compromised or has a problem, it will have an effect on breathing, swallowing coordination.
Hi everyone, welcome to episode 2 on our podcast Dysphagia Matters, evidence-based talks with Julia and Jule. Today we are really happy to welcome Dr. Ulrike Frank as our guest.
We have both known Ulrike for several years now, as a supervisor, lecturer, great researcher and clinician, and somewhat she feels like a mentor to us. She always has some good advice and help to offer. Regarding her background, Ulrike is a speech and language pathologist. She did her PhD in the interdisciplinary management of tracheostomized patients and is since then an associate researcher at the University of Potsdam in Germany. She founded the Swallowing Research Lab in 2009 at the University of Potsdam. Ulrike's research focus is, amongst others, in the coordination of respiration and swallowing, the effects of respiratory treatments on swallowing in patients with dysphagia, and the application of surface electromyography biofeedback in dysphagia therapy. Together with her sister Katrin Frank, a physiotherapist and respiratory therapist, she is well known in Germany for their excellent training on interdisciplinary treatment approaches in dysphagia therapy, and since last year also regarding COVID-19. So we might as well invite her again to talk about that. But for today, we're really happy to welcome her to talk about the fundamentals of respiratory swallow coordination. Welcome, Ulrike.
Yes, thank you. Thank you for this kind introduction. And thank you for inviting me. And congratulations to your very good and interesting and inspiring new podcast. I'm very happy to be here. Thank you.
Thanks so much, Ulrike, for coming on the podcast and for talking about this topic. So I read a blog post that started exactly with the question that I had in mind. But because George Barnes has phrased it so nicely, I would like to cite him here from his blog, feasibleswallowsolutions.com. So there he writes, "The respiratory system is not an area we learned a lot about in grad school, or any other time for that matter. We may have read an article or two on the important factors of lung health to consider when managing dysphagia and the risk for aspiration pneumonia. But have we ever truly studied the respiratory system itself? Probably not. But if yes, I applaud you, because it's an extremely important area for us not only to be aware of, but to understand well." So Ulrike, why do you think is it important for us to understand the respiratory system? I assume you do think so, otherwise you wouldn't be spending so much time with it.
Yes, you're completely right. And I think the respiratory system is, one of the most interesting and also challenging body functions. And of course, I think that nobody can really understand any body function without having at least a basic knowledge about respiration and the contribution that respiration has on the body function. Just to give some examples from the vegetative functions or the functional system, I think in all these systems, the respiratory system has a vital role. It's a kind of fuel and motor for any body function we have. So this includes any functional motor ability, all our cognitive skills. And of course, all these are skills and abilities that are very important for speech language pathologists. For example, brain function like language processing, speech motor planning, and producing comprehensible and intelligible and natural speech would not work without a good and sufficient respiratory system. Because, of course, we need airflow to phonate and to articulate. And we need air and oxygenation to provide oxygen for our brain cells. So I think it's very obvious that the respiratory system is a kind of foundation for any function we are treating as SLPs. When we go away from SLPs and just to natural life, anybody can understand that when we have good respiratory function, we feel happy, we feel skilled, we feel that we can do anything we can do. But, still, when we have a minor respiratory disease, or when we feel out of breath, or when we have no sufficient airflow and respiratory function, we cannot think that we can feel happy or skilled or anything like that. And I think this shows the dominant role the respiratory system has for our body functions. And if the respiratory system is compromised and we have trouble with breathing adequately, all other functions will be subordinated. And this includes articulation, swallowing, and all other functions. So I think respiratory function is at least something we should also think about when we care about our basic and primary areas we treat as speech-language pathologists.
That makes totally sense. And it's like you say, it's such a vital system in our body and we could not survive without it. But then I wonder why, if such a system is so important, why do we learn so little about it in our educational training? I guess most students or clinicians feel that way. Do you have any idea why that is the case?
Well, that's a difficult and very challenging question right at the beginning.
So sorry about that.
No, but it's a very important question. Yeah, I think there are a lot of reasons for that. And one reason is that, well, respiration seems so natural and so self-evident that most people may think that, well, we need not care about it. It's just there. And well, it's a basic function. And maybe in a way it's more interesting to look at more complex or seemingly more complex functions. And the role of the respiratory therapist, well, when we look at therapies, is not clearly defined. The physios do respiratory therapy. They don't learn much about that as well, more than we do, but not enough. And I think the notion that respiration and the respiratory system is so important, particularly for swallowing function, is, well, quite new. So we have studies, of course, from the early 90s, so this is 20, 30 years ago, and people began to care about respiratory swallowing coordination, for example. But compared to other aspects of swallowing physiology, this is a rather new field. And I think it just did not or has not yet made its way in our study programs in a way that, well, it should. Yeah, we have so many things to teach. We have so many things to learn. So maybe it's the case that we take something like respiration as well. Well, it's just there. And, well, it's so simple. It is not, we know, but we think that it's so simple. And, well, I think it still has a long way to go. But I feel, and I'm dealing with all these for 20 years now, almost 20 years now, I think people are much more aware now of the role of respiration for swallowing now and are much more interested. And, well, sometimes the clinical experience comes first, and then education comes very, very, very much later. But I hope that we will have the situation that we can teach more about that. But that also implies that we have time to teach that. And this is very difficult in our education schedules at the moment because we have to teach so many things. So a long answer to a short question, I'm sorry.
Well, that's totally okay. I mean, it makes sense. And I think it's a good way of trying to explain why it lags behind and why we haven't learned that much about it yet. But I guess now we can take the opportunity and try to discuss it and share our conversation with our listeners.
Yes, sure. I think this is podcasts like yours is a very good way to teach people and to educate people about that, because it's, well, you can hear it just when you do anything else, cleaning the room or riding your bike or doing anything, and you can learn something. So I think this is better than sitting in a university room.
That leads perfectly to the next question. Would you mind explaining what we as clinicians working with dysphagia need to know, or what we should know about respiration and how the respiratory swallow coordination works?
Yes, I think a good start is that respiration and swallowing have some basic fundamental control within the brainstem. And these are two centers, control centers, we have control centers for respiration and we have control centers for swallowing. And I think most dysphagia therapists are aware of the vital role the swallowing centers play for swallowing. So they generate a synergistic and basic motor sequence that promotes bolus flow, that promotes airway closure. So the swallowing centers, they are really responsible for bringing the bolus from the mouth through the pharynx into the esophagus, while protecting the airway biomechanically. So we know that the airway is protected by glottic closure, by epiglottic inversion, all these things. But also we have these respiratory pattern generators, and they also have a fundamental task. They need to generate a fundamental sequence for our respiration. That is, that we have a regular pattern of inspiration, expiration, inspiration, expiration. They control that we breathe regularly based on information they get from the periphery. So the respiratory centers, they know how much oxygen is in the blood, for example, and how much carbon dioxide has been exhaled. So, and based on these informations, these respiratory pattern generators, they control respiratory rate, for example. So they increase respiratory rate to improve oxygenation, for example. So this is their basic task.
So they would do that, for example, when we walk and then we start running. So then they would come into the play of our vital role, that they activate it and more oxygen is spread through the blood.
Yes.
Like this?
Yeah.
Okay.
Yeah, like this. This is a very good example. We need more oxygen if we exhaust ourselves, and then they increase respiratory rate and respiratory volume to stabilize our body functions, of course. Yeah. And traditionally we have thought there was a notion that the respiratory system and the swallowing system have to coordinate in some way, because we knew that during bolus passage through the pharynx, we have a kind of respiratory pause. And everybody thought, well, years and years and years and decades ago, thought that the swallowing system just like interrupts respiration or stops respiration. But then people became aware of the fact that there must be a vital role and an active role of the respiratory system during swallowing. And this respiratory active role is that the respiratory pattern generators generate actively a respiratory pause during swallowing. So in the moment the swallow is triggered, the respiratory system stops exhalation actively. It's not the result, it's not identical to glottic closure. So of course the swallowing pattern generators establish the glottic closure, but additionally to this glottic closure, the respiratory system stops the exhalation and generates an expiratory pause. Some people call this swallowing apnea, but most researchers who work on breathing swallowing coordination prefer to call it something like respiratory pause that accommodates swallowing. Well, this is very long, so most people call it just swallowing specific respiratory pause. Yeah, and that's because swallowing apnea sounds like a pathology, something that's pathological, but it's not pathological. It is an activity of the respiratory pattern generators. And it is important to understand that both team partners, swallowing and respiration, have an active role, because clinically this active interruption contributes to a very regular breathing swallowing coordination pattern. And that is that we swallow during exhalation. This is a very stable and regular pattern. And well, all healthy children and adults exhibit this stable pattern. We exhale after swallowing. We swallow during exhalation. And we swallow at a point in time during exhalation when we have at least 1/3 of our expiratory volume left. So we don't swallow just at the end of the exhalation phase, but just in the middle, you can say. And this stable breathing swallowing coordination and this active pause of the respiratory system has two main effects for swallowing safety. First, you can, by doing this, you can generate subglottic pressure. So while the glottis closes, this airflow generates pressure underneath the glottis, and this pressure improves laryngeal closure. And the other aspect is that when you aspirate, you can elicit an effective cough as a response to this aspiration because you still have lung volume left. Yeah. And I think these are really things that are important to know, because when we acknowledge that respiration has an active part in swallowing safety, we can understand better why swallowing is unsafe in patients who have respiratory diseases. So we call this respiratory dysphagia. Yeah. And this is because the respiratory system cannot really establish its functional and beneficial and promoting role for swallowing safety.
This is really interesting. Thanks so much. And if you look at it from the research that has been done, it's such a big shift, I think, to find out that the respiratory system takes an active role in swallowing instead of a passive role, or yes, that swallowing is even, if you say swallowing is kind of controlling the respiration. So that's really interesting. And when I was preparing for this episode, I paid more attention to my own respiratory swallow coordination. Funnily, I started coughing more often, and a few times it felt like I was penetrating my food and drinks. What I also recognized is that when I'm really thirsty, I drink a whole glass of water, at least 200 milliliters, without putting the glass down. And I also recognized that I did not have any regular respiratory swallow pattern or rhythm anymore. So I sometimes swallowed after taking a really deep breath, then after exhaling, or sometimes even when I felt completely out of breath. So do you have any explanations for that, or was it just because I paid too much attention to it and I screwed with my physiological coordination and voluntarily modulated it?
Oh, this is a very, very interesting question and a challenging question indeed. And I think your observation is based on the fact that your cognitive abilities are very good. So,
thank you.
by using cognitive strategies, cognitive strategies can have an impact on breathing, swallowing coordination, and this is what we try to use when we do specific treatment protocols. Despite the fact that you can change your breathing, swallowing coordination when you're concentrating on it, or when you put very much cognitive load on that, it's really, really very hard to cheat your brainstem functions. We have tried this here in our lab several times. We have tried to cheat breathing, swallowing coordination for a long time. And I can say it's really hard. And maybe, this is why treatment strategies that are based on behavioral methods like swallow at a certain time in your respiratory cycle are really, really hard to learn, and they need much intensity in treatment. But yes, of course, it is the case that breathing, swallowing coordination can be influenced by certain factors. One is cognitive strategies, but other external factors can also modulate breathing, swallowing coordination. And this is very good, because by this we can eat and drink different textures, different volumes. And breathing, swallowing coordination adapts to different bolus volumes. As you said, you swallowed 200 milliliters. And it would be another pattern when you swallow a smaller volume of liquid, for example. Yeah. So influence and factors can be volume or texture of food, drinking larger volumes, for example, particularly when you are thirsty, will promote sequential swallowing. Yeah, so you anticipate that you will need to swallow these 200 milliliters sequentially. And in a way, this is more challenging for your swallowing system. Well, I think this is obvious because you have to put 1, 2, 3, 4, 5 swallows in a row. And your breathing swallowing coordination system adapts or takes up this challenge by putting your first swallow earlier in the expiration phase. So you inhale and then you start to swallow because you anticipate that you will have to swallow 4 or 5 or 6 times. And you don't do that consciously. This is something your breathing swallowing coordination does automatically, or well, you have learned to do that because you have learned to manage larger volumes of food during your oralization as a baby. Yeah. And also you can adapt to different textures of food. For example, we talked about this respiratory pause that accommodates swallowing earlier. When you drink liquids, this respiratory pause is initiated earlier. When you eat, swallow food like, well, something you have to chew, something like a piece of bread, yeah, and the texture is much more, well, is more viscous, and then you will have a slower pharyngeal transport phase and your respiratory pause will occur later because the respiratory system doesn't want to have a very, very, very long respiratory pause and a very, very long interruption in expiration, obviously. So the respiratory pause comes as late as it can come because, well, we don't want to have such a long interruption. Yeah, so this is how you adapt to different volumes or textures of food, for example.
Okay, and are there any other factors besides volume or texture that can influence the respiratory swallow coordination?
Yes, if you mean so kind of external factors, so factors that are okay. Yeah, well, besides different properties or characteristics of food that we can adapt to or learned to adapt to, we also adapt to our aging processes or to our developmental changes. So when we are born, well, we first have the task to develop, to grow our orofacial structures and our respiratory structures, obviously. And then when we become older, our structures change as well. We call this sarcopenia. Yeah. So we have muscle loss, our skeleton changes. And also to these age-related changes, our breathing swallowing coordination adapts very well. So we have a kind of flexibility here, and we can learn to swallow with this altered or changed or aging structures. When we talk about swallowing in older patients, we don't talk about a normal swallow, we talk about functional swallowing. So how does the system change without having, a dysphagia or a higher risk of aspiration? And breathing swallowing coordination is one of these systems that compensates for aging. So, for example, a few minutes ago, we talked about this ability of the respiratory system to flexibly initiate the respiratory pause earlier when you swallow liquids, later when you have a solid bolus, for example. Yeah, and the older you get, the earlier you initiate your respiratory pause, and this is to adapt for the longer pharyngeal phase, for example, and to put more safety to the swallowing process and to bolus transport through the pharynx when the pharynx muscles are older and more compromised and, you are in a state of what we call presbyphagia.
So did you say as we get older, our the respiratory stop is initiated earlier because our pharyngeal phase gets longer. Is that correct?
Yes. So when the respiratory pause is the component of breathing, swallowing coordination, that is more flexible. Mm-hmm. And so when we get older, we somehow use this respiratory pause earlier.
Okay, so we pause earlier, we have a longer pharyngeal phase, but then, or if you explain it that way, it makes so much sense why we have why we have phenomena like presbyphagia, like you said, or then the age-related respiration system. So then it's quite obvious why elderly people cough more often. It doesn't mean that they really have dysphagia, but like presbyphagia, or it becomes so much more complicated to swallow efficiently. Is that the case?
Yes, in a way, and I'm very happy that you ask again, because I think it's necessary to understand that when we talk about age-related compensation processes, then we have to acknowledge the fact that all these compensation processes come at a cost. So if I initiate my respiratory pause, for example, and make it longer, then this is not a good situation for the respiratory system, because this time kind of is lost for gas exchange. And the respiratory system will do that as long as it can afford to do that. But if anything happens, so if we get very, very old and the respiratory system becomes compromised as well.
And we tend to get a lot older.
Yes, and we tend to get a lot older. Yes, right. And or if I have trouble breathing because I develop some kind of, respiratory disease, or I have an acute situation, then these compensation strategies, they break down. Yes, they get lost. You can't afford any longer to have this long and very early respiratory pause. And this is probably the point when presbyphagia, that is not clinically relevant, turns into secondary presbyphagia. So a status when the aging swallowing system shifts to developing clinically relevant changes and becoming more prone to aspiration, to coughing, and to, dysphagia. Yes. So I think we have to understand that when we talk about compensation, these compensatory processes will not work any longer if other factors come into the game.
Yeah, that's really interesting. And I think that's really important for us to keep in mind. I mean, or from my experience, I can say oftentimes it's so difficult to differentiate clinically or even with instrumental assessments if this was something that was before, for example, a stroke, if they had presbyphagia already and they maybe managed quite well, but then they have a stroke and maybe it's only in quote unquote only presbyphagia, but they can't manage their compensation strategies anymore. So there's not much that is adding to it due to the stroke, but it's just that the whole system doesn't work anymore. And that makes it so complex, I think, when assessing swallowing and looking for swallowing disorders, what the actual cause is, the underlying pathophysiology. So, and now we are much more aware of the fact of breathing and the role of breathing when in swallowing. So wow, that makes it so complex.
Yes, but I think, there's also good news when we talk about...
I love good news. Thank you.
Yeah, it's always good. Always best to have good news. And I think based on the notion that we have a flexible breathing, swallowing coordination system, researchers like Curtis and Michel Trochi have thought about strategies that we can teach, older patients or patients with Parkinson's disease. They worked a lot with patients with Parkinson's disease, and they thought about, can we teach these patients strategies that they can regain some kind of compensation, or can they learn some kind of compensatory strategies? And it seems that this might be successful. So for example, these researchers, they gave patients verbal cues to swallow. So they observed their respiratory cycle, and whenever they were in the expiration phase, they gave them a verbal cue and said, okay, swallow now. And this was very effective. And interestingly, when they gave this verbal cue early in the expiration phase, then this was very effective, and it led to a restabilization of breathing swallowing coordination. So patients from such a simple method like giving a verbal cue, the Parkinson's patients had very much benefit, and they stabilized their breathing swallowing coordination, and they had a benefit from their higher lung volumes. And that was not that effective when the verbal cue was given at the end of the expiration phase. And they also did they tried another strategy, and that was they asked the patients to hold the bolus in the oral cavity for a moment and then swallow it. So kind of bolus hold method, very simple. And I think it's obvious that particularly for patients with Parkinson's disease, it is very important to make the instructions just simple and replicable. And also these Parkinson's patients had very, very much benefit from this bolus hold technique. So when they held the liquid in the mouth and swallowed and got the swallowing prompt, then they swallowed much better, and they could reorganize their breathing swallowing coordination much better. And I think this is good news. I think obviously because even the compromised system, compromised by a disease or by aging or whatever, is readaptable and can learn and is flexible. And I think this is very important for us as therapists.
Yeah, and then even with a neurodegenerative disease. So I have one question regarding what you have just referenced there. So it makes sense to me that in Parkinson's, if you give a verbal cue, then the initiation of the swallow is maybe better placed time-wise, for example. So as we know, Parkinson's people have problems with the self-initiation of movements. But what do you think is the cause, or why is it that the bolus hold improves the respiratory swallow coordination in Parkinson's disease?
I think it gave the patients more time to initiate the swallow by themselves. Of course, we know this bolus hold strategy that is effective in other diseases as well. And I think the mechanism is always that you can really promote the self-prompting of swallowing and give your structures time to coordinate. And I think this bolus hold technique should be combined, particularly in Parkinson's disease, with a verbal prompt in the early stages of a therapy, of an intervention, or with other external prompts until the patient can initiate better on a self-initiation basis, something like that. So I think you can combine that, or you can, better patients combine that with making the patient aware of his respiratory cycle and have an instruction like, hold the bolus, observe your respiratory cycle, and please swallow when you exhale. But it depends on the cognitive abilities, of course, of the patient.
Yes, definitely, especially in Parkinson's patients.
Mm-hmm.
Great, thanks so much. That's really interesting, and it gives us already an insight on what we can do with a specific patient population.
Okay, we've talked a lot about elderly patients and how the respiratory swallow coordination changes with age, with getting older. Can you maybe tell us a little bit about the beginnings of that development? So I mean the development in infants, because intrauterine swallow activities have been observed in babies of 12 weeks gestational age, so very early on as well. So we start early with swallowing, but we obviously don't breathe via the air digestive tract at that time. But considering that we don't have the possibility to prepare for months and to practice how to coordinate breathing and swallowing, what happens in regards to the respiratory swallow coordination when we are born?
This is really very, very interesting question, and it's challenging to do research in that field, and for these obvious reasons we don't have much data about that, but we have really interesting data from New Zealand, from Bronwyn Kelly, who studied 10 healthy newborns, and these newborns were born at term. I think this is important to know. I come back to that later. So these newborns, as you said, had some practice in swallowing during their intrauterine development, and then they were born, and well, now the respiratory partner comes into play. So this is the first moment when this interaction between respiration and swallowing is the task for these children. And interestingly, during the first 48 hours after birth, we see a kind of adult-like swallowing pattern. So we see a dominant exhale, swallow, exhale pattern. So it seems that we are born with this basic motor sequence of, post-swallow expiration. And then this pattern becomes more variable. So during the first week of life, we see very variable patterns. And this is interpreted as showing the variability and the flexibility of the system. So this basic pattern experiences influences. It experiences the task of breathing adequately, of first nutrition, of course. Yeah, so breastfeeding or bottle feeding and all these challenges. And we see that this leads to much variability in breathing, swallowing coordination during the first week. And then the pattern returns to the post-swallow expiration pattern. So we can reorganize that and come back to this very stable and safe breathing, swallowing coordination pattern. And we have other major shifts, and these occur during the first year of life. So we must say that Bronwyn Kelly only looked at the first 12 months of life, yeah, and she studied 10 babies. That's not much, but it's really challenging to make such a study. But she showed that at 6 months and at 12 months of life, there are other kind of milestones when we see more variability and somehow the breathing, swallowing coordination coming, well, into more variability, more inspiratory swallows. And she relates this to maturational changes and to anatomical changes. And one thing we can observe here is that this variability is when breastfeeding is progressively discontinued and the children begin to eat more solid food. So when the breastfeeding phase is just coming slowly to an end, and other food textures and volumes come into the play, then we see this. Well, I don't want to call it disruption. It's more variability again and a learning process. And this is just normal. This is normal adaptation, normal variability, nothing we should care about nothing we should be concerned about. But I said that before that it's important to know that these data comes from normal and term-born children, because in preterm children, the situation can be different. These children come into our world after birth, and maybe, and in most of them, the respiratory system is not truly already developed. So they have trouble breathing, the lung has not matured, and they have really much trouble with breathing, swallowing, coordination. And this can really take weeks to months until they really can establish a stable breathing, swallowing coordination pattern. Again, we don't have much data on that, but I think this is one of the most basic challenges for dysphagia or nutritional therapists, for these very, very young and immaturely born children.
And do you have an idea where the problem might lie with these children? What happens in their brainstems?
I don't know. I think it's immaturity. Immaturity, well, I think particularly of the respiratory system, because the respiratory system, as I said in the beginning, when the respiratory system is compromised and doesn't work well and has trouble establishing oxygenation, then everything else will become subordinated. And a newborn has a respiratory rate of, 40 and even more when you are born preterm, and in such a high rate, we just can't control our breathing, swallowing coordination adequately. We see that if we come back to the adults, we see that in adults with respiratory diseases as well. Rapid, shallow breathing is one of the main reasons for breathing, swallowing discoordination in adults as well. So I think it's immaturity and the struggling respiratory system that just can't afford to establish good breathing, swallowing coordination.
Yeah, maybe also because it's just one of many things that these babies have to deal with.
Yes, one of many things.
Moment.
Yeah. Mm-hmm.
Yeah, I think before we start talking about the assessment and treatment, which we have touched a little bit already, but I would like to go back to what happens when a respiratory or neurological disease is present. So you have been talking a little bit about Parkinson's disease, but maybe some really common neurological diseases like stroke maybe as well, or tracheostomized patients, or respiratory diseases like COPD. So I know we can't cover this really in depth here, but can you maybe explain a little bit what happens with the respiratory system in these when patients have these conditions?
You mean what happens to breathing, swallowing coordination system?
Yes, yeah. Sorry.
Okay.
Yeah.
No problem. Yeah, I hope that it has become clear that respiration and swallowing are like two team partners who have to coordinate and work together in order to establish safe swallowing together. And if one of these team partners becomes compromised or has a problem, it will have an effect on breathing, swallowing coordination. And well, in our work as SLPs, we have, all kinds of patients with all kinds of neurological diseases, like, as you mentioned, stroke, Parkinson's disease, ALS, whatever. And we also have patients who have respiratory diseases like COPD or COVID-19. This is a newer disease we have to deal with, and all these. So I think it should not be surprising that we see breathing, swallowing discoordination in these patients. And in fact, we do see that. So when people learned or became aware of the importance of breathing, swallowing coordination, first thing was that research turned to these patients in order to investigate this breathing, swallowing coordination, in order to have a kind of further piece of explanation of the aspiration rates, for example, for persons with COPD. And in fact, these studies found that, for example, in patients with stroke, you see very often inspiratory swallows, mid-inspiratory swallows. And these inspiratory swallows, the more they occur, the higher is the aspiration risk in these patients. So this is one example how breathing, swallowing discoordination is related to aspiration in stroke patients. In COPD patients, we know that breathing, swallowing discoordination occurs mostly when the patients are in a state of acute exacerbation of their disease. So acute pneumonia, acute bronchial infections. So when the respiratory system really has a problem, it has in fact, we have high fever, we have high respiratory rates, and the typical respiratory pattern of these COPD, acutely ill COPD patients is this rapid, shallow breathing. And when they exhibit this, then you also see breathing, swallowing discoordination. And of course, also these patients have a lot of respiratory exhaustion. So on the one hand, when these patients, the COPD patients, when they try to eat a meal, they aspirate more and have to cough more because they aspirate because of their breathing, swallowing discoordination. Coughing is exhaustive, and then they stop eating. And this is a kind of vicious circle. They eat less because they have trouble breathing and they have trouble swallowing. Because they eat less, they have more risk of exacerbation, or their recovery rates or their recovery phase becomes longer. So we have a kind of vicious circle in these patients. And good news, or we talked about we want to have good news. Good news is that this improves when the acute exacerbation improves. So when they return to a better respiration pattern, then usually breathing, swallowing discoordination gets better as well. But we have to care about them, and we have to care about that they don't get into this exacerbation, and have to teach them strategies how to deal with that. Yeah. And I think tracheostomized patients, one of our major tasks is to wean the patient off the tracheostomy. And to wean them off the tube, we decuff the tube and we occlude the tube. And this we do because we want to re-establish subglottic airflow and laryngeal airflow. And for a very long time, we know that when we do that, and when we do tube deflation and tube occlusion, then we have less aspiration. And now, since we know about the importance of subglottic pressure and of the respiratory system, we have an explanation for that. Because reinstalling or reestablishing laryngeal airflow also means that you reestablish subglottic airflow. And this underlines or emphasizes the role of subglottic pressure and of the respiratory system for aspiration control and for aspiration prevention. This is one part where the tracheostomized patient benefits from respiration. And also some studies have shown that the respiratory swallowing coordination is worse with the tube inflated, also if the cuff inflated, and with transstomatal breathing, and it becomes better when you re-establish translaryngeal airflow. So we see that even this stable coordination pattern can have a benefit and can react to changes in respiratory airflow, be it through the lower airway, so through the stoma, transstomatal respiration, or translaryngeal respiration. And breathing, swallowing coordination can even adapt to that.
Thanks so much. That's really interesting what you've said about these different patient populations. And so before we start about how we can treat them, I wonder, how can we actually assess the respiratory swallow coordination in clinical practice?
Unfortunately, there's no standardized or validated assessment tool or tools for diagnosing breathing, swallowing coordinations. It's just clinical experience, but people are working on that. And I hope that some validated tool will be available very soon. But another good news is that breathing, swallowing coordination can really be observed very easily and just with clinical methods, and you don't need a fancy or complicated instrumentation for that, or just a 6 weeks training session or for that. You just need to observe, and you need to focus on certain parameters. And first, you should just observe the patient and observe his respiratory cycle and the moment when the swallow occurs in this respiratory cycle. Or in other words, you have to identify what is the dominant breathing, swallowing coordination pattern in that particular patient. Is it that the patient swallows within the expiratory phase or within the inspiratory phase, or just between these stages? So at the end of expiration or at the end of inspiration. So you should have a notion about the regular patterning or the dominant patterning, and this you can just observe. You sometimes you have to observe over several minutes. Because, well, when swallowing frequency is very, very low, then you have to be a little patient. But it's very interesting also to observe whether there are differences between spontaneous swallows in breathing swallowing coordination or facilitated swallows. So if you facilitate swallowing by manual facilitation or by a kind of bolus, this situation can be different, and you should observe and document all that. And second, it's very important also to observe certain parameters of respiratory function, meaning that you document parameters like respiratory rate and respiratory activity of the respiratory muscles, particularly of the respiratory auxiliary muscles. Because when you observe a patient who is at rest, and this patient has a very high respiratory rate or uses his respiratory auxiliary muscles during rest, then this means that something is wrong with the respiratory system and he has really effort breathing. And this is just not a good basic situation for breathing swallowing coordination. So if you now do a water screening test or whatever with a patient, then you will really put the patient into danger and into a high risk of aspiration. So you should document during your assessment basic respiratory parameters like rate and muscle function. And also you should obtain measurements of potential cough effectiveness. If possible, you should obtain a measurement of peak cough flow, like just simple spirometry, that you know, okay, what's your expiratory flow and what is your cough flow? Is it sufficient for expiratory, for cough effectiveness? And also you should have a measurement or, well, some information about bronchial secretion management. Yeah, because there's an interrelationship between bronchial secretion and gas exchange tissue and the respiratory rate.
How could I assess them and judge?
You need radiology for that. Yes, okay. To really be sure how much and where the bronchial secretions are. You really need radiology, but you can also, sometimes you can also make a palpation. You can feel that by just putting your hand on the chest or by hearing it with a auscultation, so with a stethoscope, or you can do that. But usually you obtain information about bronchial secretions in non-tracheostomized patients. You can obtain them just by radiological findings. This is most easy. And in tracheostomized patients, you can just observe what you suction from the tube or what is coughed out of the tube. And then you will have a very good picture of the quality and of the quantity of bronchial secretions as well. Yes. And these respiratory parameters give you an idea of the respiratory situation and the indication for applying respiratory therapy. Because without a functional respiratory system and a stable and good functional respiratory system, you don't have the foundation for good breathing swallowing coordination, because again, a compromised respiratory system will subordinate swallowing, and breathing swallowing coordination is less important for the impaired respiratory system. So in sum, as said before, it's just three things. Observe coordination pattern, observe basic respiratory parameters, and observe measures of cough effectiveness. And then you have a good notion about what you have to do in treatment.
Yeah, that's actually less complicated than I thought it would be. And I just remembered a video of a patient you showed in one of your webinars where she was lying in bed, but she seemed like she was running a marathon. Her respiratory rate was so high, but all she was doing was lying in bed. So that's really important that you mentioned this again, that if we note something like this, then we know the person is already struggling with their breathing. So and if we start adding something like drinking or eating, this is like the person is like at the top of their level. So it's like we would, if you imagine if we are running a marathon and we drink while we're running and we're like at the 40K mark, it's nearly impossible, right? So it's really important to have this comparison, I think, to really understand what the patient is going through and what the state of the patient is at that moment.
Yeah, this is a very good example.
Okay. And in case we recognize an impairment of the respiratory swallow coordination, then in our diagnostic sessions, what treatment options do we have, and what's the current evidence on that?
Well, not surprising, respiratory treatments are really vital, and it's vital to stabilize the respiratory function as a foundation. And the focus here is to increase the tidal volume and to reduce the respiratory rate. So all techniques, methods, or whatever you do that lead to deeper inspiration, longer expiration, to more tidal volume will also lead to a better oxygenation. And when the pattern generators in the brainstem observe that, there's more oxygen around in the blood, they will, adapt to that and decrease the respiratory rate because, the body doesn't want to work more than it has to. So it's very economical feeling. So if you make your patient breathe more deeply or have a deeper inspiration, to have a longer expiration, then you will have a direct effect on respiratory rate as well. And there's from the physiotherapeutic literature and from respiratory treatment literature, there's some evidence around that this is really working very well. And there's an immediate effect often, but you have to do it longer to have a maintaining or effect on that. Yeah.
Okay. And sorry, can you maybe give a quick explanation on what tidal volume is?
Tidal volume is just the amount of air you breathe in and breathe out. So 500 milliliters when you are resting, it's just the volume, the air volume that you breathe in and out during one respiratory cycle.
Okay, thanks.
But of course, we have also other treatment options. I also talked about these behavioral treatment strategies that Curtis and colleagues used. So these prompted swallows or the bolus hold swallows. We have also evidence from a very interesting study from Martin Harris from 2015 that we can also use biofeedback strategies. And I'm sure that this will be very interesting for you because you are working on biofeedback as well. So Martin Harris investigated a group of head and neck cancer patients, and she visualized their breathing swallowing coordination patterns. So they visualized the swallowing activity by having a certain visualization of muscle function during swallowing, and they had the respiratory system visualized by respiratory pressure transducer. So the patients could see their respiratory rhythm, inspiration, expiration, inspiration, and they could see their swallowing activity at the same time on a monitor. And they asked the patients to swallow when they feel that they need to swallow. And when they swallow, they should do it in the expiratory phase. So whenever they see their expiratory phase and they need to swallow, they should do it just like there. And this biofeedback supported treatment was very effective in this group of patients. And this brings us to a little problem that are connected to these behavioral and biofeedback strategies, because you really, really need an alert patient, and you need a patient with enough cognitive ability to just perform these trainings. And the other problem is that all these treatment strategies were embedded in a high intensity treatment protocol with really, really high repetition rates of one and the same task.
We will link the discussed studies by James Curtis, Bronwyn Kelly, and Bonnie Martin Harris and their colleagues in the show notes. So if you're interested, go check them out.
If we want to implement that in our clinical practice, we must be aware which patients are suitable for such approaches. Yeah, so do they have the alertness and the cognitive abilities? And we need to get much better to have these biofeedback methods developed so they are attractive, and then that they attract high frequent learning by, gamification or by visualization, because you really need high intensity treatment protocols to be effective there. With patients who are not that alert or not that responsive, or who cannot participate as well as these patients, well, I think at the moment you are just left to respiratory strategies, to normalization, stabilization of respiratory function. But we see that also by these techniques, we have a restabilization of breathing, swallowing coordination as well.
Okay, great. That's really interesting. Also the part with the biofeedback, and as you have guessed correctly, that is of big interest to us. So before we come to an end, is there anything you would like to add? Did we forget any important aspects?
No, I don't think so. So maybe kind of take-home message. I think it is clear that respiration is really something that is fascinating and very important for us, and that it's also one of the basic aspects of safe swallowing. So it's the foundation of safe oral intake as well. And that when we have patients who have impaired swallowing, we should also look at the respiratory side and find reasons for the swallowing impairments also on the respiratory side. It's not necessarily the case that they have respiratory impairment, but we should be aware that we should look at that in order to identify these patients, these problems when they are there. So, and on the other side, when we have patients with respiratory problems, we should anticipate that they have trouble swallowing as well. So a good dysphagia, a good respiratory treatment or good treatment of respiratory diseases should also imply swallowing assessment. And I think we must get better in developing tools and assessment tools and also treatment tools, particularly when it comes to breathing, swallowing coordination. But I think this is how we started. Why don't we know much about that? Maybe in a way we are still in a stage that we try to understand these mechanisms. But I think, it's really, really necessary that we get back from this first step or promote further and now begin to develop devices and ideas and assessment tools that we can really use in clinical practice and put that into education as well.
Yes, really important.
Yeah, thank you so much for your time and for talking to us on the podcast. We can highly recommend attending one of Ulrike's trainings if you're a German-speaking clinician.
Yeah, thanks so much, Ulrike. We really appreciate it. We hope you, our listeners, enjoyed this episode as well. If you would like to get in touch with us and stay informed about upcoming episodes, follow us on Instagram at Dysphagia Matters, on Twitter at Dysphagia PCast, or visit our website at dysphagiamatters.org. Thanks so much for listening. Thank you, Ulrike, for coming on the show, and take care, everyone.
Thank you for having me. Thank you.
Bye.
Bye.
Bye.